As Cindy said, I'm Waverly.
I'm Jane.
And we're research coordinators for Dr. Bird in the trauma department. We also work with Travis Sullivan, who I think most of you saw present earlier. And so our goal for this presentation is to just tell you a little bit about our research efforts and how they have the potential to affect patient care. So for a little bit of background, trauma is the leading cause of preventable death in children, and 4% of trauma activation patients don't survive until discharge. Of those deaths, a quarter are deemed preventable, and then half of preventable deaths are related to errors during the initial trauma resuscitation, which is kind of the area that our research focuses on the most. So the errors that happen in trauma resuscitations can be classified into three groups. The first is knowledge-based errors, and these occur when a provider has incorrect or inadequate knowledge about a certain procedure or treatment. The second type is skill-based errors, and these occur when a provider incorrectly performs a procedure or treatment. And then the third type is rule-based errors, and these are related to following procedures correctly. So clinical evidence-based procedures, if those are followed incorrectly, it's a rule-based error. And rule-based errors are particularly significant because 85% of errors that result in preventable death are classified as rule-based errors. So thinking about that, how can we prevent these errors? As we looked at with the rule-based errors being the biggest thing, interventions such as policies or clinical algorithms don't have as much of an impact because they don't address the rule-based error. And so we, with our research here, are focused on decision support, which provides or gives providers guidance and allows them to follow procedures to the best of their ability. Most of our research is funded by an NIH grant. It's called an R01 grant, and we're focused on real-time decision support. So that's decision support during a trauma resuscitation that gives providers hints as they go along or tips to support their decisions. The most basic type of decision support would involve something where a provider can input manually different values or information as a resuscitation occurs. And so an example of this is we have a digital form of the trauma checklist that a charge nurse fills out as you go along. And so the surgical team leader will pick this up and input vital signs and information about the primary and secondary survey, and that'll inform our computer system. But as most of you probably know, that a lot of clinical situations can get quite hectic, particularly in trauma. And so in a trauma resuscitation, there can easily be a dozen people, all of whom are trying to perform different tasks in parallel. So like in this little illustrated example, we have nurse left who might be trying to take a manual blood pressure, the surgical resident or MP who's calling out the primary and secondary survey, and then nurse right who's trying to get the patient hooked up to vitals. And so all these people are working in parallel, but they might not be aware of what the other is doing. And you can imagine that it would be hard for someone who's also trying to participate in patient care to be able to put all of these into a manual decision support tool. And so that's why we want to develop a decision support tool that focuses on three goals. First, we want it to be able to recognize and track team goals in real time. And so an example of this would be IV access. So IV access is something that is critical in most trauma resuscitations. It's something that the team should have in mind and that many nurses do just automatically. But if this isn't performed or isn't performed in a timely manner, it can impact patient care. So we want our decision support to be able to recognize and keep track of that goal. Second, we want it to be able to identify and prioritize activities. So sticking with the IV access, certain activities associated with that might be like a tourniquet that can be recognized, or performing a flush to indicate that IV access is being established or that it's successful. And then the third thing that we want our decision support tool to be able to do is recommend a plan of activities. So if, with the IV access example, say 5 to 10 minutes have gone by and there's no IV access established, our decision support would ideally be able to recognize this and then move forward with recommending IV placement or IO placement if IV has not been successful. And so in order to fulfill this decision support tool, we have to collect a lot of data. And so this is a picture of Code Room 1 here at the hospital in the ED. And we have it pretty well rigged up to collect 4 types of data. The first of which is video. And so, does this have a little laser pointer? Okay, we have 2 different types of cameras in the trauma bay. The first is ocularis cameras, which are in the ceiling here, and they have 3 views. They capture the trauma bay from 3 views, and we use them for research. They're very helpful, but the rest of the trauma team also uses them for performance review and different trauma video review. And then we also have a camera up here that's above the patient bed, and this is called the Z camera. We use it specifically for computer vision, which helps in our decision support algorithm. The second type of data that we collect is audio, and we have this big microphone along the back wall that is running pretty much whenever anyone is in the trauma bay, and that collects audio that we can use to inform our decision support. There's also the digital checklist, which lives on the charge nurse stand there and is used by the surgical coordinator. And finally, we collect vital signs from the vital sign monitor during all trauma resuscitations, and so we have that timestamped and can use that to inform decision support. Also, this is just helpful to know that eventually when we create display alerts and stuff, they will be projected on this screen. We use it right now in simulation where the decision aids will go to help the team leaders. And this is a view, these are the ocularis camera views. So we have above bed, from the foot of the bed, and then kind of looking out at the team leaders here. And we use these for performance review and to track activities that is going along in the department. Most of our research with decision support is done in conjunction with a team of computer scientists at Drexel University and a team of computer engineers at Rutgers. And the Rutgers team specializes in machine learning. And so this sounds complex, but there's a pretty simple algorithm or idea behind machine learning. And that is you provide training data, and then you feed it through the computer program. And then hopefully you get improved performance as you feed more and more training data into the program. And so our job here at Children's and our research team is to provide the training data. And we do this by taking the camera views from Ocularis. We download all consented trauma cases. We have videos for those stored. And so we watch the videos and then track kind of provider by provider, person by person in the trauma bay, which activities are being performed and at what specific time. And so we can go through and say, this person is starting the bear hugger at this specific time, and it was nurse left who did it. And so we take once we create that, we call that the ground truth data. So it's kind of like a record of what actually happened in the trauma bay. And so once we have the ground truth, we give the recorded log of events along with the coupled video, and we feed that through a computer system that's designed to recognize videos in the hopes of getting improved performance. And so once we've trained a model, we move on to the testing phase, which is where we give the computer system videos that have not been coded. So they don't have the aim to ground truth. And the computer kind of has to decide and make us what, I'll click out of this. So the computer system has to decide what it thinks is going on. And so here we have kind of like the output that we get from that training. And for a couple examples here, the computer thought that manual inline was being performed at this specific time interval. And then here is how confident the computer was in that decision, or in that selection. And so we see this one is a 0.45, so the computer wasn't super sure that it wasn't very confident in that. But here we have a 0.8, so the computer was much more confident that a back activity or like a log roll was occurring at those times. And so with these ones where it's less confident, we go through, Jane and I, and watch the video clip, the timestamps that it created, and we watch it through and see if that manual inline activity is occurring. And so here it looks like it's not occurring, and so we could just say activity does not exist. And then that information gets fed back into the computer training system and improves the data, and eventually the computer vision is able to recognize specific activities. We do a similar process with audio. So here's our big microphone that we just installed, and it collects audio data from resuscitation and then gives us an output based on kind of what the computer thinks is happening. And then we have a human who is either Jane or myself or one of our interns, listen to the resuscitation stuff, type out what they say, and then, or what they hear, and then select what type of activity is occurring and what the intention of the speech is. So here it says like he's got good peripheral DP pulses, and so we know that that's a circulation activity. It's a C on the ABCs, so we select that, and the intention is to report results. But for example, if someone was asking like, hey, can you get a pulse? That would be a request to perform intention with the same activity. And then this is a lot, but it is the readout that we get from the audio training. So we have what the computer thinks happened here, or what the computer thinks was said, and then we have a human transcribed version, so what humans believe was said, and the activities that we've coded. And this helps us be able to recognize things like GCS. So a GCS value, there's not really many audio or computer vision cues, like you can't really visibly see if someone's talking about GCS, so that's a place that audio has been very helpful for us, and it can select out, like, this is a GCS value and GCS is 15. And then our third tool that we use, the type of data that we use to collect, is the digital checklist, which I talked about briefly at the beginning. This is a tool that the surgical coordinators use during resuscitation. And so it's just a tablet that lives on the charge nurse's desk, and they can go through and input, there's a page for pre-hospital information, any pre-arrival information they get, they can input, and then go through the primary and secondary survey along with any adjuncts. And this allows us to have information to train our computer decision support system, but also eventually it can be used to provide decision support aids to the providers. So kind of an overview, you have the computer vision and the checklist and the audio data all going into one computer system. We collect the vitals from the vital monitor, which can provide a lot of good information about patient status, and then that is all combined to give a recommendation. And so recommendations can kind of be presented in many different ways. One that we've tried is a little pop-up on the checklist that, based on specific vital signs that are put in or visual or audio cues, it would tell you to perform a certain activity, such as blood transfusion is one that we're working on now. And we also have on that computer screen that's on the back wall of the trauma department, or the trauma bay, there's a TV that we can turn on to have give specific decision support aids. Now, this is kind of a splinter study that we're doing that is just to prove of concept that all of these systems can work together to provide decision support to providers. And so we're doing a simulation study where we're bringing in ED doctors and fellows and surgical coordinators to run through kind of a simulated scenario where they have certain vital signs, they have the age of the patient, different injury information, and then as the resuscitation progresses, we use computer vision and audio to recognize certain tasks and provide recommendations. So here's a little clip of Jane and I play the role of nurse and the junior resident, and both nurses, we have lots of roles. And so we have a mannequin on the bed, and you can see here is where the decision aid is projected. And so it has minor recommendations and then a major focus. And then the clock here starts when the computer vision can recognize when the patient is wheeled in, and it'll start the clock kind of similar to how you hit the clock when you start a trauma. And then in theory, we have reminders here which are different activities that can be performed or should be performed in the trauma resuscitation. And then you have the patient on the bed and the computer vision watching the patient. And so say as Jane and I put on the C-collar in the simulation, that C-collar mobilization cue there will go away. And then same with if you add oxygen, that will also go away until all of the reminders are complete. And you can have major recommendations. And so these, such as like consider blood transfusion, would be initiated based on vital signs that are input into the checklist. And that will be, it'll be consider if it's a slightly varied or like, if there's one Z-score deviation from the normal blood pressure. So it'll say consider and it'll flash yellow just to kind of give the team an idea that, hey, maybe these vitals aren't looking great and it's something that you should consider. And then if they get worse, it'll say blood transfusion recommended and flash red so that the whole team is on the same page, and it'll can help the nursing staff be ready to prep blood, make sure there's an IV in, make sure the blood bank is called if NCP is activated, and stuff like that. And so that's kind of the main overview of our decision support systems and our simulation studies.
Okay, so going off of that, the next project I want to talk about is also focused on decreasing time to treatment, in this case, neurosurgical intervention. And so rather than focusing on solely what is occurring in the code room, we wanted to improve the information available to providers to help them more quickly and confidently identify patients needing neurosurgical intervention. So what's the problem? So traumatic brain injury, or TBI, is the leading cause of death and disability following injury in adults and children are especially prone to negative developmental, behavioral, and cognitive skills after TBI. And so it can be difficult to determine which patients will have continued intracranial hemorrhage or will develop refractory intracranial hypertension. And it is presumed, but not yet proven, that timely intervention can help improve these outcomes. So some past efforts, people have tried to define criteria to facilitate the clinical decision for neurosurgical intervention. So early evacuation, decompression, or just close observation of these TBI injuries. So one of these is the Brain Trauma Foundation defines criteria for neurosurgical intervention that can be used in the emergency department and during hospitalization for children and adults with primary TBI. But these recommendations, they even admit themselves, they're supported by some clinical uncertainty. Another study is the PCARN study, which has a decision support aid to identify children at risk for clinically significant TBI, but it doesn't identify patients who might need neurosurgical intervention. Then CITI, the Surgical Intervention for Traumatic Injury scoring system, is the only validated triage tool to identify children at risk for receiving a craniotomy or a craniectomy. So we wanted to do something along the same lines as that, so a similar tool to predict the neurosurgical intervention after injury, but a tool that takes advantage of the information that's immediately available to us upon arrival to the emergency department, such as mechanism of injury or whether or not they received pre-hospital CPR. Also, with CITI and other triage tools that I just talked about, if you don't know all the input measures, then the tool becomes useless. And so we wanted to create a tool that can still make a prediction even without all the available or possible information. We also wanted to create a tool that can be used without time-consuming input measures, such as a head CT finding, which could take us more time before the neurosurgical intervention decision. And then finally, we wanted to create something that can be updated with information from the emergency department as it becomes available to improve the quality of the prediction of the probability. So with all these functions in mind, we chose to work on a type of probabilities network called the Bayesian network. Bayesian networks allow the user to input a variety of variables. So in this case, we have rain and sprinkler are input variables. And it will output the probability of an event occurring. So in this case, we're looking at the probability of grass being wet. So just like to give more context, so like you can see that the probability of it raining is 2% or 20%, 0.2. And so then if you look over at the rain sprinkler side, if it's raining, then the probability of your sprinkler being on is only 1%, because like why would you want to turn your sprinkler on if your grass is already getting wet from the rain? So then your output variable, if your sprinkler is on and it's raining, there's a 99% chance that your grass is wet. And so we're kind of implementing this very basic version into whether or not the patient needs neurosurgical intervention. So we needed a very large data set. So we took the data from the National Trauma Data Bank from 2017 to 2019, which gave us about 400,000 children and adolescents to look through. And we needed to decide what variables would be helpful and what variables would be immediately available to providers. So we trained our model using patient injury and resuscitation characteristics from about a third of that data set, so 120,000 patients. So to determine how these variables interact with each other and how best to structure our network, we basically put all this information into this place called in the Bayesian lab, so that we could use a data-driven approach rather than clinical judgment by itself. And we let the program select the variables to include. So eventually it came out to 4 predictor variables: mechanism injury, total GCS, whether or not they had pre-hospital CPR, and then their pupillary response. And after externally validating this model, we hope to eventually be able to implement this into clinical practice using the tools from the R01 project that Waverly just described. So the next study I want to talk about is the Compensatory Reserve Index, or the CRI study. This is a multi-institutional study. We've recently begun in partnership with the Children's Hospital of Colorado and Phoenix Children's Hospital. And so this study is focused on the early identification of patients that may be in compensated hemorrhagic shock, and it uses a very different tool, this tablet. So Dr. Steve Moulton from Colorado Children's has created an algorithm that uses machine learning that looks at a patient's pulse ox waveform and continually outputs a compensatory reserve index value, or the CRI value. So these values range from 0 to 1 and correspond with the patient's ability to compensate for intravascular blood loss. A CRI value of 1 equates to normal volemia, while a value of 0 equates to the patient entering uncompensated shock. And values between 0 and 1 indicate the proportion of reserve remaining before hemodynamic decompensation. So this is a lot like the fuel gauge of a car, how it indicates the amount of fuel remaining in the tank. And so when a patient loses the intravascular volume due to bleeding or dehydration, the tank empties, and the CRI will go down. And then with appropriate fluid resuscitation, the tank refills and the CRI will go up. So there have already been several studies validating the device in adults, resulting in FDA approval for adult patients. So what we want to do, along with the Colorado and Phoenix, we're testing the device in pediatric trauma patients to validate the device and determine the sensitivity and specificity values, as you can see on this graph. So that sensitivity specificity values, that means like how good different cutoff points may be at identifying patients in hypovolemic shock. So basically anything below 0.7 is bad. So for this study, we have the algorithm uploaded onto 2 tablets that look like this. And these tablets connect to the patient's pulse ox strip. And so once connected, the tablet captures the patient's heart rate, the patient's pulse ox and pulse ox waveform and gives a CRI value that's continuously updating. So we're placing these devices on all trauma patients in the code room that arrive when a device is available and when there's a research member, so Waverly and I is there to put it on. So if you happen to be one of the nurses in the trauma bay, you might have us asking you to put the pulse ox onto their finger. So the device is left on for 4 to 24 hours, depending on the severity of the given patient's injuries. So we'll also conduct a thorough review of each patient's EMR to determine the date and time of any recorded interventions or information that may indicate or affect this patient's intravascular volume. So those include surgical or angiographic interventions, the patient's traditional vital signs, laboratory results, imaging findings, and any fluids or medications that they may have received. And then Waverly or I will go back and we'll align these interventions with the observed CRI values at that time to see how well they predict or alter the CRI values. So ultimately, after validating the CRI algorithm, Dr. Moulton plans to incorporate it into the Philips monitors, so the value can be displayed for all the patients along with their normal vital signs that you see. So for you guys, if you're working in the emergency department, surgical care, the PICU, PACU, OR, neuroscience, or the float pool, you may see this device on some of your patients. And so our team would really appreciate if you could keep the device connected to the patient's finger and until like the specified time. We will normally come and remove it or plug it in. So we ask that you keep it plugged in if it is plugged in. And then if you have to remove it for some reason, please store it in the shift coordinator's office or in the integration room if you're in the PICU. There's also a USB cord that you can see over there that connects the device to the pulse ox. So we ask that if you do happen to remove it, please keep the USB connected to this device and do not throw it out with the pulse ox. But again, normally Waverly or I will be the one that's removing the device anyway, and we'll also plug it in and consent the parents and answer any questions they might have. So really, you don't have to worry about this too much.
Also, the CRI device can be left on if the patient goes to CT.
Oh yeah.
If you're in the ED especially. But yeah, we'll handle all of that. Yes. Yeah. Mm-hmm. No, that's fine.
That's great.
They collect data by like 5-second intervals, so like once you plug it back in, it'll just start going again. So that would be awesome. Mm-hmm.
Yeah. It's just this tablet right here. So it's just it looks like an iPad with a little handle. And it normally, we also have like a little sticker that goes over it so that you don't look at the values that are printed out, because obviously it's not validated yet, so we don't want any of that information to be used for clinical decision making. But yeah, normally it's just this tablet with the pulse ox connected. Yeah. Any other questions? Okay. Well, thank you.